sir. Greetings and a warm welcome to everyone. I am Rituparna, the assigned moderator from Clarinet. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us from across the country today. We are indeed fortunate enough to have the valuable support of the esteemed doctors, and I express my sincere gratitude to each one of you for dedicating your time to be with us today. So please allow me a moment to introduce our platform Clarinet. Clarinet is India's largest live digital semi-platform, providing a space for the doctors to create and share innovative medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Professor Dr. S. Arulraj, sir, a prominent consultant and an honorary faculty. Sir is holding the degrees of MD, PhD, DSc, FRCP, LNG, and MBA. Currently, Sir is a distinguished honorary professor at Dr. MGR Medical University, Chennai. He is also the past national president of API and IMA and also the past Commonwealth President CMA UK. Last but not the least, he is a proud recipient of Dr. B.C. Roy Award and for also the founder of Dr. S. Arulraj Hospitals, Tuticorin. Now, without much ado, I would like to give you a brief overview of today's topic, that is obesity, a gateway to cardiometabolic syndrome. Obesity raises the risk of dyslipidemia, hypertension, and type 2 diabetes, which are all well established cardiometabolic risk factors and components of metabolic syndrome. Other risk factors, including maternal smoking, postnatal growth patterns, the influence of dietary components on gene expression, and the impact of fructose intake on uric acid levels, are also quite significant contributors. So, without any further delay, sir, I would like to hand over the session quickly to you to further enlighten us on this topic today. So, over to you, sir. Kindly proceed with your talk.
Thank you very much for the nice introduction of the topic as well as myself. Extreme participants and our doctor colleagues, I would like to briefly talk to you on a very important topic today. That is obesity. You may wonder why so many chaps are enjoying food and not doing anything, but they are obese, they are enjoying their life. Why should we bother about it? By the end of this session, you will understand that obesity is a very important risk factor for cardiometabolic syndrome. That is why this topic I have taken it up. I'll just present to you the synopsis of this, and at the end of it, any questions I would love to answer. First of all, the definition by the Institute of Health under the Ministry of Health and Family Welfare, it shows that the term overweight or obesity refers to a body weight which is considered to be very high risk, not healthy for the human being. There are in our body, fat is the greatest insulator. We have about 30 to 35 billion fat cells. When weight is not controlled, the number of cells will increase. Obesity has recently become a global phenomenon. Therefore, we are very much concerned on this today, and it has serious complications, as said by the moderator. The term obesity comes from the Latin term obese or obesus, which means stout, fat, or plump. And overweight or obesity defined as an abnormal or excessive fat accumulation that presents a risk to health. And we go by the body mass index. That is, when it is above 25, we call it as overweight. Above 30, we call it as obese. We have certain measurement like BMA, waist circumference, and skin fold thickness. And waist circumference seems to be more accurate for children. There are many other measurements, including MRI. And this issue of obesity seems to be on epidemic proportions today. And over 4 million people are dying every year, as a result of overweight according to the disease burden. That is why we are here today to address on this. The second component is, one is about obesity, which we have defined. Second component is cardiometabolic syndrome. What is that? It's a group of metabolic abnormalities. Goes clinically by an abdominal obesity and insulin-resistant glucose metabolism and dyslipidemia and increased blood pressure. And there are many other names also, like an insulin-resistant syndrome, syndrome X, and Raven syndrome, or beer belly syndrome. Many things are there. Why it is important? there is increased free fatty acid in this syndrome that leads to an insulin resistance and an impaired glucose tolerance. And it stimulates the hepatic VLDL and triglyceride production, leading to increased serum triglyceride level. It stimulates vasoconstrictions and increases sodium absorption, possibly leading on to hypertension also. This cardiometabolic syndrome is now recognized as a separate entity by WHO and American Society of Endocrinology. Visceral fat is the result of imbalance between energy intake and energy expenditure. It creates a pro-inflammatory state and pro-thrombotic state. Reducing the free fatty acid in the plasma may be the potential target for cardiometabolic syndrome. Coming to the types of obesity, when the BMI is between 30 to 35, we said 25 is okay. Above 25 is, obesity. And it is a class 1 when it is between 30 to 35, class 2, 35 to 40. Above 40, it is called as class 3 or severe obesity. Above 40, it is again, severe obesity. And there can be above 40, 45, a morbid obesity. Above 50, it is called a super obesity. These are various classifications for clinicians to adopt. We are talking about obesity. What is the common causes of obesity? Important cause is excess food and less movement or physical activity. When there is an excess, diet in the form of a high calorie diet, such as fast foods or baked foods or vending machine snacks, that is the commonest cause for weight gain both in children and adults. Lack of exercise. WHO today calls it a physical activity. Doesn't say as an exercise, physical activity. When you are just sitting and watching the TV or spending time on your mobile without any exercise, you get this problem. There can be a familial factor as there is history of obesity in the family. Mother is obese, father is obese. There is a genetic component also involved. There are psychological factors when there is depression or an isolation. There is a dealing with the emotions and socioeconomic factors. More food is available and certain medications like steroids, lithium, amitriptyline, propranolol, all of them can increase obesity. All of us know very well there are endocrine causes. That is a Cushing syndrome. All of us know a moon-like face and obesity, growth hormone deficiency, short stature, something like a cretin, and a hyperinsulinism. Hypothyroidism always has obesity and fat accumulation. Pseudo-hypoparathyroidism. With a short metacarpal, there are subcutaneous calcifications and they have an obesity also added. There is an entity called as constitutional obesity. That is, this is due to an imbalance between intake and expenditure. There are no organic causes. These children are tall for age. They are normal development, but obesity is proportional. Hypothalamic obesity, when there is a tumor and a surgery or an infection or a radiation done for the hypothalamic region, always obesity comes. There are any number of genetic syndromes. The commonest one is Alstom syndrome and Down syndrome or a Turner syndrome or Frolic syndrome. Any number of endocrine abnormalities are there which cause obesity. What is the incidence of obesity? The World Obesity Atlas in 2022 says 1 in 5 women and 1 in 7 men will be living with obesity by 2030. If you see the data from 2015 to 2016 up to 21, there is an increase in the obesity incidence both in men and women. And the greatest number of people live in the low middle income countries, and now it is tripling in low income countries. That is why it becomes an important cause of concern for non-communicable diseases. There is a data in 24 recent data in Hindu says 40% of city school-going children are obesity or overweight. Doctors blame it on fast food and gadget use, only sitting and using mobile. Why we are worried about? There is increased food intake and less energy expenditure leads to obesity. What happens with this obesity? It's a pro-inflammatory stage, and it is an insulin resistant that leads to type 2 diabetes, dyslipidemia, prothrombotic stage, hypertension, non-alcoholic fatty liver disease, ultimately ending into atherosclerotic cardiovascular disease. The incidence more, we will see that. I mean, this is the cause for obesity. When there is increased food and less expenditure, you get it. And there are certain clinical signs. I mean, these all of us are know. I mean, lethargy, breathlessness, and the disproportionate facial feature. Main important thing is for a male, some breast region adiposity is very, very common here. And that is always a sign of obesity. Big belly syndrome, beer belly syndrome, always sign of obesity. A male external genitalia may appear disproportionately small, and a knock knees or genu valcum is very, very common in obese people. And how to make a diagnosis? As I said, body mass index. What is body mass index? When you divide the person's weight in kilogram by his, height in meters, you get the BMI. Normal is up to 25. Above 25, overweight. Above 30, obese. Extreme obesity, above 40, which we already seen that. These are the health complications. Why we are worried about, why we are addressing on this subject? Coronary artery disease, very common. Type 2 diabetes is common. And then hypertension is common. Non-alcoholic fatty liver disease, which we call metabolic associated, MAFLD, increased risk of disability. And there is a separate entity called obesity-induced cardiomyopathy. Not a cardiomyopathy, but it is a obesity cardiomyopathy is also an entity which leads to failure. And obesity and lifestyle diseases. When they, that is it, diabetes, hypertension, dyslipidemia. In underweight, it is fine. Normal weight, fine. When it goes on increasing, when there is a rise in the weight, the level of obesity, you have an increased incidence of diabetes, hypertension, and dyslipidemia. Therefore, it is always causing a great risk to a vascular disease. Obesity and diabetes. Obesity and sedentary life increases the risk of type 2 diabetes. The insulin resistance, non-esterified beta fatty acids are coming up, and insulin resistance and beta cell dysfunction also comes. Hence, the incidence of diabetes is going up in people with obesity. Obesity and diabetes, already there can be genetic, environmental factors, increased food intake and less exercise leads to increased obesity and fatty acids, and then goes to insulin resistance, beta cell dysfunction, ultimately ends in type 2 diabetes. And coming to dyslipidemia, it can be a high cholesterol level, due to an abdominal obesity, and there is every component of the lipids are increased, or sometimes when there is the ratio between normal weight, overweight, and obese, and all factors, high TG, high HDL, and LDL, all are, increased. Excess of triglyceride and bad cholesterol or LDL cholesterol are highly riskier, and it is very common, in our obesity people. This is the mechanism of dyslipidemia. See, it increases the free fatty acids, which goes into the blood circulation, and it impairs lipolysis, which leads to increased chylomicron formation. The hallmark of dyslipidemia and obesity is hypertriglyceridemia, and that is very important. And there can be a large amount of VLDL, and the lipolysis is affected. TG is the commonest one. This causes a vascular constriction and endothelial dysfunction, and both at renal level, at vascular level, leads down to hypertension. The hypertension is a renal mechanism, a vascular mechanism, and it leads to cardiovascular problems like cardiac hypertrophy and a plaque rupture leading on to coronary artery disease. Obesity contributes to the development of hypertension via the interaction of dietary, genetic, epigenetic, and environmental factors. And cardiac and renal abnormalities, as we discussed, are very common here. The obesity versus hypertension. Obesity is a major risk factor for systemic hypertension. And obesity also causes cardiovascular and renal diseases. Obesity is the gateway to atherosclerosis, abdominal obesity, metabolic syndrome. There is a vascular dysregulation, high blood pressure, diabetes, atherogenic dyslipidemia, leading on to atherosclerosis. I mean, this is not a regular, not away from regular stories, but these are our regular pathogenesis of hypertension, diabetes, and then vascular disease, myocardial disease in people who are obese. In obesity and cardiovascular system, and the myocardium itself, fat cells are deposited, goes to fibrosis, and a myocardial dysfunction, heart failure comes. When there is involvement of the smooth muscles of the vascular system and endothelium goes to coronary artery disease, same thing can happen in the, renal system also. And as I told you, insulin resistant and endothelial dysfunction are the commonest causes of, cardiovascular disease. Cardiovascular disease can lead on to sudden, by a volume overload or a pressure overload, or can be a hypertension or an electrical remodeling goes to trigger, and sudden death is also not uncommon in cases of obesity, which we should remember. And the coronary artery disease in obese and non-obese is very, different. It is more common in obese. And the weight loss can profoundly influence a number of major risk factors, including hypertension, dyslipidemia, insulin resistance, and T2DM. This is the cardiovascular system. When there are, obesity, there is a hypertension created, dyslipidemia created, vascular endothelium, metabolic abnormalities, all of them lead to increased cardiovascular risk factor, heart failure, coronary disease, including a sudden cardiac death also. This is obesity is a gateway to renal injury by the lipids. The lipids in the, convoluted tubules are being compressed, and endothelial dysfunction leads on to, angiotensinogen increase, and hypertension also, renal damage also comes here. And in the liver, non-alcoholic fatty liver disease, since it is, causing a fatty acids production, and it is very much, affected, it leads to an insulin resistant. In cases of COVID, the mortality in people who were obese in COVID were very, very high because of the comorbid conditions as well as to the sleep apnea syndrome. And coming to the last entity in obesity, cancers. We have seen about diabetes, dyslipidemia, hypertension, cardiovascular, renovascular, now coming to cancer. Compared to non-obese people and obese people, every cancer is more common. Endometrial cancer, esophageal adenocarcinoma, gastric, liver, kidney, and multiple myeloma, meningioma, pancreatic, and menopausal ovarian, thyroid, any malignancy, it's 1 to 2 times compared to the non-obese people. And obesity leading to heart failure, CVD, and stroke, it's really high. Both coronary artery disease, heart failure, and stroke are more common, irrespective of the age and sex in people with obesity. We are talking about obesity cardiomyopathy, a word about it. It's a myocardial change caused entirely or predominantly by obesity, independent of other cardiac risk factors like coronary artery disease or hypertension. And this leads on to, a decreased lifetime of this patient. Another entity is sarcopenic obesity. Sarcopenia is a one when there is a muscle mass is coming down and the muscle power is also coming down. And sarcopenia can occur in obesity also. Obesity increased fat that can, infiltrate into the muscles, and it can cause the, decrease in the muscle mass and can definitely precipitate sarcopenia. Obesity exacerbates sarcopenia. Obesity increases the infiltration of fat into muscle. Obesity lowers the physical function and increases the risk of morbidity. The European Working Group on this study has said that it can be when there is a low muscle strength, we call it as a probable sarcopenia. When there is a low muscle strength plus muscle mass, it is sarcopenia. Severe sarcopenia, strength is low, muscle mass is low, performance is also low. That is an entity called as sarcopenic obesity. severity. The complications of sarcopenic obesity is high prevalence of diabetes, hypertension, dyslipidemia. That is why it is called a gateway to metabolic syndrome. Higher mortality, more depression, higher frailty, disability, admission. There is an entity called as musculo-osteoarthro-neuropathic syndrome, MON syndrome, which is very common in, sarcopenic obesity. There is another entity which we talked about, normal weight obesity. They are normal, but their fat cells adequate BMI, but increased body, fat percentage is there. They don't suffer much, but still it is a risk factor. Conditions can be associated with normal weight obesity or blood pressure, lipid profile, homocysteine concentration, all are increased. It can go on to a pro-inflammatory stress as well as a insulin resistant and oxidative stress. And nutrigenetics and nutrigenomics of the interaction with the food component and the human genome. Always, from individual to individual, there is a genomic variation. And another entity by name childhood obesity. We are very much now concerned about childhood obesity because childhood obesity always opens the gateway to metabolic syndrome. In the early adulthood, it's a cause of concern because severe obesity, insulin resistance may progress to type 2 diabetes at the earliest. The clue is acanthosis nigricans. See the neck of these people, that is a marker of insulin resistance, and the high cholesterol and high TG levels are a risk factor to coronary artery disease in future, and their puberty can also be delayed. And prevention of childhood obesity, limiting the screen time, and only 60 minutes per day is the activity for children. Encourage walking at school, use mass media, both governments, NGOs, WHO, everybody should stress that the obesity in childhood has to be prevented, and that comes into food choices and physical activities and reduced screening time. A family approach has to be there. Now we are concerned about the management. We have now seen, what amount of cardiometabolic abnormalities and life-threatening diseases are common in obesity. Now, how to manage it? As you all know, there is a physical activity is a major one. Without that, nothing can improve. And some of the drugs should be adhered to. Medical nutrition therapy, that is a healthy eating. Low calories, low carbohydrates, low sugar, low fat, low salt as to medical nutrition therapy. And the three key pillars of obesity management are supporting the nutrition activity. One is psychological. Though they keep on eating, they are psychologically upset. Therefore, they need motivation. Certain pharmacological therapies and surgical therapies are also useful, which we will quickly go through. This total calories, for an adult, for a woman, 1,000 and male 1,200. That should be the calorie. And in a severe obesity, even up to 900 or 600 calories we need to do. Regular aerobic exercises. Eating healthy is very important. It's an important statement. These are the various physical activities, behavior therapies, building confidence in them. A few drugs are still useful. Simotriptan is still, useful. Orlistat is useful. Fluoxetine is always useful. And this Orlistat is a FDA approved drug. And locazepine can be always used. Sibutramine, fenfluramine, or leptin trust can always be used. But they have only temporary benefits. Obesity, bariatric surgery seems to go, very well. A sleeve gastrectomy, always RUN, why always very useful. Earlier they used to do open, then they went to laparoscopic, now through endoscopic. In people who are resistant to obesity, we need to consider them for life-saving measures. And there are certain concepts which I'll just push it across to you. One is an Ayurvedic concept. The termed as, Medora, or the Charak Samhita, Susruta, all these places, Ayurvedic concept is very good to keep the body fit. The Surya Namaskar in the morning is very useful. They are all very much inculcated in our Indian literature. Yoga has a very important role to reduce the obesity, not only in our country, throughout the world. Now, ladies and gentlemen, once obesity, why we are so much concerned of obesity is once it is controlled, it leads to reduction in insulin resistance. It leads to reduction in blood pressure. It leads to reduction in the risk of cardiovascular disease like cardiac failure or myocardial infarction, a reduction in the risk of stroke, reduction in the risk of cancer. Therefore, obesity has to be reduced. Now, ladies and gentlemen, the actionables are obesity hastens diabetes, hypertension, CVD, and cancer. Morbidity and mortality is increased. NCD is easily contracted. Diabetes 20%, coronary disease 28%, hypertension 28%, heart failure 17%, stroke 6%. More important thing is the lifetime of the human is reduced from 10 to 20 years. And the simple is food restriction and physical activity. Childhood obesity is on the uptrend and it is a great concern. Nearly 40% of children, who are obese, they get into a lot of cardiometabolic problems in the years to come. The medical therapy, surgical therapy, endoscopic interventions have to be considered. In a resistant case of obesity, health education to the youth and especially mothers is the key. I'm sure. I have conveyed you what is obesity, how it comes, what disability it causes to the humans, how to control it. I'm sure you will apply it on your patients from today onwards and see that we see a healthy India. Thank you, ladies and gentlemen.
Thank you very much, sir. So, with all your permission, can we move ahead with the questions now?
Yes, go ahead.
Okay, sir. So, the very first question is, how effective is the how does obesity contribute to GRD diseases and other gastrointestinal disorders?
Obesity causes GERD because of the chest which is being widened, the gastroesophageal sphincter is being brought out and is being stretched. Therefore, a lot of regurgitation takes place. It takes place in about 10% of the people with obesity. Other GI problems are it can cause irritable bowel syndrome. All of them have a lot of anxiety, though they may look fine, but internally they are not very much settled. Therefore, it leads to irritable bowel syndrome. These are the two common GI problems, obesity we are able to see. Hello?
Thank you so much, sir, for your valuable answer. So now moving on to the next question for today, sir. The next question is, how does obesity influence the risk of developing gallbladder diseases and pancreatitis?
See, since the main, problems start in the liver, because the obesity leads on to a fatty liver, wherein fatty acids are being secreted, which leads to insulin resistance. Therefore, the chances of a gallbladder disease is more common, and gallbladder stone is more common in people with obesity compared to the lean population. It is, as per literature, if my memory goes right, 18 to 20% is more common gallstones in obese people. Therefore, we should avoid.
Thank you so much, sir, for your valuable answers and knowledge. So as of now, we haven't received any further questions, sir. So thank you once again, all the dear participants, for continuously being with us on our platform and sharing such valuable insights. And requesting you all to suggest any other different topic based on this particular specialty, and we would be very glad to conduct a session on our platform with related topic. So thank you once again, sir, for generously contributing your time and effort on our platform today, and looking forward to host you again very soon in another interactive session in the near future. So till then, sir, stay safe and healthy and have a nice day. Thank you very much, sir.
Thank you so
Thank
much.
you, sir.
Thank you.